Okay. I think I got that started, the recording started. I did, okay. I'm Erin Field. I think a lot of us know each other. I'm one of the acute care surgeons here. I also round in the surgical intensive care unit. I recently took over as the surgical clerkship director for Wayne, so I supervise a lot of the medical students that come and do their surgical clerkship with us. So that's how I occupy my time as of late. So I was asked to come and talk today about nutrition in the ICU, which is kind of fun because it's one of my favorite things to talk about, and not many people really want to hear about it. So I think it's been about a year plus since I gave a nutrition talk for the urologist of all people, and then a year or so before that it was up in Alpena, Michigan. So it's not such a hot topic around these parts. So anyway, I'll just start off with some objectives for today. I put quite a bit of time. I think what I was told was you guys wanted to hear about enteral and parenteral nutrition, indications, contraindications, some risk-benefit type stuff. But when I sat down and really got to thinking about it, there's the best reference for the current kind of state-of-the-art management of enteral and parenteral nutrition in ICU patients in this country is the newly published Guidelines in the Journal of Parenteral and Enteral Nutrition and Critical Care Medicine from February 2016. And I am going to go into that at the end, but really the basis for a lot of the decisions that those guidelines give us, recommendations, are based on the level of risk that your patient has. For example, it'll say, when do I do this or when do I do that, or in which patient do I consider this versus that. And it is almost every single statement is qualified by for the at-risk patient, for the high-risk patient, for the low-risk patient. So I'm gonna, while you eat and enjoy some of your noontime conference, I'm gonna take us through how you ascertain that. So then you can pick up the guidelines or Google them, and then you can answer the question, because you'll know how to figure out, is my patient at risk or not. So that's the bulk of what we're going to talk about, is this diagnosis of nutritional status. And I'll go through a little bit of this because you guys have enough to keep up with taking care of ICU patients and learning everything you need to learn in fellowship, and not many of us go back through the nutrition literature and see what's new. And then we'll talk a little bit about inflammation and nutritional status, because that's one of the cornerstones of some of the changes in the diagnosis. And then like I said, like I promised, towards the end I'll get a little bit more into some of the specific recommendations and strategies. So to start out, malnutrition is a nutrition imbalance, either a lack of adequate calories, protein, or other nutrients that are needed for tissue maintenance and repair. And in a lot of cases, our patients are needing to repair either acute kidney injury or lung injury, surgical incisions in the surgical ICU, and of course your patients also many times have large wounds to heal. So identification and treatment are a concern, and it's often unrecognized. So I know on this last slide I talked about it being a lack of calories and protein, but really, it's just sort of an imbalance. It can be due to just a vastly increased, requirement or need by the patient in the setting of an intake that's just not adequate. And there's also a significant role that inflammatory and hypermetabolic conditions contribute. And this isn't new, you guys are familiar with the fact that burn patients, which is one of the classic examples that we always talk about, burn patients in nutrition have this, large metabolic requirement. But more on that is becoming available in just, other critically ill patients. So in the late 90s, the Joint Commission mandated nutrition screening. So this is actually happening in our patients in the hospital within 24 hours of hospital admission. And in floor patients, the bedside nurses do a lot of this assessment. And in our ICUs, our dietitians are doing it. And so you probably are already aware of that. But in case you're not, every single one of your patients is getting a nutrition assessment. So some of the issues that have existed in the past is that there are various diagnostic codes that are kind of confusing, and you probably see that if you go to add malnutrition to your problem list in Epic, and it pops up with like 20 different options. So the issue of inflammation is that it impacts the nutrition status of the patient in multiple ways. One, it's considered a risk factor. So if the patient's admitted and has some inflammatory state, and this can be sort of broadly defined. One example is sarcopenic obesity. So a lot of patients are admitted are obese, but relatively have very poor lean body tissue. And obesity in and of itself is considered a mild chronic inflammatory state. So things like just general inflammatory conditions like that, not necessarily even the acute inflammatory conditions that you guys see every day in septic patients or etc. And then the other thing, and this won't be new to you guys, but the influence of inflammation on our usual assessment parameters. So I'm going to talk a little bit more on that on the next slide. And inflammation and its role in contributing to a suboptimal response. So if you're giving patients calories and protein, how much are they able to utilize what you're giving them in the setting of inflammation? So I like to have at least one slide, and you guys are probably, way far ahead of most of the general surgeons that I work with. Not to cut us down, but I still have my, my residents come through at least the surgical ICU and ask us to trend pre-albumins and albumins in our patient, and I can see these like grit her teeth, So at any rate, what in the past we might have considered markers of nutrition status are really markers of inflammation. And like I said, I think I probably don't have to say that to you, but this is a nice slide because it also points out, fever, leukocytosis. These are all markers of inflammation that we should be looking for in our patients to tell us whether or not they're at risk, potentially at risk for malnutrition. So, with that little background, we sort of go into this etiology-based malnutrition definitions. And this is from the JPEN in 2009. But we sort of use this nutritional risk, compromised intake or loss of body mass. So compromised intake is pretty much anyone in the intensive care unit. I mean, there's probably more exceptions to that in the surgical ICU, patients who have had elective operations and come for, a lot of our patients come for flap monitoring or things like that, but they're in and out of the ICU in 6 to 12, 24 hours. They're not really at risk. They don't really fall into this category, depending on the other comorbid conditions. But is inflammation present? And that's where we start to sort of differentiate like starvation-related malnutrition, so in somebody whose intake is chronically restricted, versus a chronic disease-related malnutrition, and we do see examples of that, versus someone with a marked inflammatory response with an acute disease or injury-related malnutrition, severe pneumonia, major surgery, traumatic brain injury. So after sort of establishing that general guideline, then Aspen went on to identify and standardize sort of these 6 areas, but I'm gonna make this hopefully simpler for you than having to remember 6. One is, insufficient energy intake. So from your history or knowledge of a patient, either from what they're able to tell you or what you're able to find out from talking to family members, have they been eating? A history of weight loss, and then I sort of lump these 3 together because this is all part of you walking in the room and taking a look at a patient. Loss of muscle mass, loss of subcutaneous fat, and okay, yeah, you might have to physically lay hands on a patient too. In your assessment of generalized fluid accumulation or edema. And then diminished functional status. Now the functional status is sometimes a little bit harder for us to get at objectively in the hospitalized patient. But the rest of this is, something that we can do. I'm not going to, I promise I'm not going to torture you with too many slides like this, but I wanted you to have an idea. So these are examples of moderate, non-severe, or severe, what they're calling moderate or severe, and then just less than 75% of estimated energy requirement for more than 7 days, and then just kind of using that as a guide. And when I'm doing my own assessment of patients, I don't get a whole lot into the exact numbers because that's what our dietitians and other people are there to help us do, but just so you have an idea of what it is that they're doing. Same thing here. I don't want to torture you with looking at charts of numbers, but just so you have a sense of that as the period of time goes on, or the acuity of the weight loss, either the amount or how fast it's happening, will put you into one category or the other of severe versus non-severe. And then the physical findings, some examples. Don't ignore the text. I just want to put up some examples. You guys see patients like this. I know I see them all the time. And fluid accumulation, another physical sign of malnutrition in our patients. And then finally, I put this up here just kind of for completeness, but in certain patient populations when this can be assessed. For example, if any of you find yourselves seeing patients, like pre-operatively in the future, that's one of the areas that this sometimes plays a role, trying to risk stratify and figure out which patients benefit from preoperative augmentation of their nutrition status. So here is this same information with the weight loss, energy intake, now flipped in a different order, your physical exam stuff and your functional state, and then going across the top, acute illness, chronic illness, and then restricted access to food, either, because we're relying on Meals on Wheels or, in situations of eating disorder, things like that. So I think for all of you guys sitting in this room and for me, what do I take from, reading these kind of position statements and stuff that lay all this information out. If I'm seeing patient in the emergency department and I'm going to take them to the operating room, they need some emergency operation, or I'm seeing a patient in the surgical ICU that's, that has pneumonia or whatever, and I'm trying to make a decision, bless you, about how aggressive I need to be, what my recommendations need to be, what my conversation is like with the patient and or their family about when I'm going to try to initiate feeding, how aggressive I'm going to get with feeding access or post-pyloric access or even TPN. If it's somebody that hasn't been eating for 3 weeks at home and they come in with a perforated colon cancer and I'm going to operate on them, I know I'm not going to be feeding them the next day. So they might already be someone that I've talked to about, even about being even aggressive with parenteral nutrition. So when I'm looking at a patient, and I think I annoy the crud out of my residents because I always am asking them these things. They've done all what they consider the important part of the history and physical, and then I walk in and ask them, so how do you get around the house? And do you use a cane or a walker? Do you leave the house? Can you walk across the parking lot? I'm always asking the stuff that doesn't seem important. And then when I am looking at the patient, I'm looking at, their temporal wasting, and I'm looking at their hands and going, oh no, this isn't good. Or their edema. And then taking the time to ask patients, when they last ate, really ate real food, when they last felt well. So, and this is part of any sort of assessment you guys normally do, and then take into consideration things like that, other markers of inflammation like white blood cell count and things like that. Height and weight, if you have it, if you can get a dry weight from clinic visits or from an estimate from family members. So again, along the lines of what does that all mean to us in the ICU. So if I find a patient and that's horribly malnourished, what does it mean to me? Why is it important? So we know malnutrition impacts complications and length of stay, and I think the emphasis in critical care nutrition is to view ourselves in the role of trying to help the patient to withstand the insult of, you fill in your patient's problem here. You guys might not even know what Mad Libs are, but that's how I kind of think about it. Your patient's delivered to you with whatever problem they might have, but if they have severe malnutrition, then part of your goal in getting them through that is not just the vent management and the sled and the right antibiotics and all that, and washing your hands when you go in and out of the room, because we have all those things to remember. But on top of that, it's trying to optimize their chances to repair their kidney, to heal their wounds, to have enough muscles to get off the ventilator and go to rehab and participate in rehab. So, at any rate, sorry, I got a little ahead of myself, and I don't want to just talk and talk. Okay. So here's a good point, because a lot of our patients, collectively, all of us, they present and we think, oh, they're okay right now. Depending on which way things go, they might be eating tomorrow or the next day. I'm not going to worry about this. They were well nourished, or maybe had some deficits, or they're not that sick. Whatever my initial assessment might be, always needs to be reassessed. it might not be present on admission. The inflammatory response of whatever's going on might go up, might go down, and the acuity of their nutrition status may change. And again, you probably see this too, like patients NPO one day for a tunneled catheter, then they're NPO the next day to go down for an LP, then they're NPO the next day to go for a wound washout, or trach, or feeding access. We have patients and Cindy Peaceful, and Nancy are with the nutrition support team, but Cindy was just showing me, when we were just talking about a patient the other day, she says, and this patient's been NPO 20 out of the last 28 days, and these are the kind of things that when you're the rounder like me, if you come on a Monday morning and it's day 28 of the patient's stay, and the resident presents and they're NPO for the tunnel cath, and you think, okay, that makes sense, and then the next day is Tuesday and you're rounding and it's hospital day 29. Well, it's sometimes the urgency with which we think about these things. So fortunately there are other people besides us that are looking at things with regard to nutrition on our patients. So I make this plea that when your dietitian or come up to you on rounds and say your patient's been NPO for the last 20 out of 28 days, that you huddle with them and try to make a plan. So I threw a little case in here just to sort of mix it up a little bit, and I got rid of the case on, I had one in here on anorexia or something, and I left the one in that's more sort of critical care oriented, so that we could all sort of see how this would work. What malnutrition syndrome would we anticipate in a polytrauma victim, and how would we confirm this? So this is too wordy, but I give you this, young, healthy guy with lots and lots of injuries. So he's going to have to heal his bones, heal his liver or whatever, spleen, liver and spleen. He's going to have to generate protein and ATP, and all this stuff's going to have to go into healing all this stuff. So he's on the ventilator. He was at Taco Bell right before this happened. He's febrile, leukocytosis, edematous. His albumin and prealbumin are low, but that's what we expect. He's hyperglycemic. So in essence, I give you sort of this, with these 6 components laid out. By history, he's well nourished previously, but the mechanism of injury is associated with such a severe inflammatory response to put him at high risk from a historical and clinical diagnosis point. And then he has some signs and exam that's consistent with acute inflammatory response. And the labs that in this scenario, because I try to make it straightforward, are supposed to support that. And he's at risk for an extended duration of compromised intake. Maybe I think in this case he has an open abdomen, and maybe people will be reluctant to feed him, even though that's not a contraindication, and perhaps he'll develop an ileus, and this and that. And the other thing, functional outcomes, this is a great example. You can't really do a functional assessment in this patient right now. So in him, our goal would be to initiate enteral feeds, and then just be aware of the need for reassessment. If he were intolerant to enteral feeds, moving on to the next step, or if he was able to support himself on food. So with that case in mind, I always like to put up a slide. I don't know what these little 10s are here, but I always like to put up a slide of sort of what contributes to malnutrition and what are some barriers. A lot of these apply to our elderly, our geriatric population, which is the number one, I don't know if you guys knew this, the number one admission diagnosis in the surgical NP4 is an elderly patient is that supposed to fall with whatever, rib fractures or little subarachnoid or something. That's our number one diagnosis. So most of our patients are fit into, you know, this sort of risk category. But I think also, you know, just being aware of your sort of organization or institutional biases, which can make it a real challenge. So what do we do? And this, I don't mean this to be gender biased. This is supposed to be a picture of some generic dietitian, but you know, hopefully, you know, there is a Tom is one of the male dietitians in the transplant division, right? So anyway, I realized that after I picked the picture. So what do we do with this information? You know, when you guys go out and, you know, maybe you got an email from a billing and coding person who wants you to put down the patient has severe versus moderate malnutrition, or shoot, they just want you to put malnutrition on the problem list. How do you decide? One, your dietitian's already done an assessment, so the easiest thing, I think, is to go and talk with them or read their note. But two, for those of you who have one of these glass things in your pocket or glass screen things, you can, you know, you probably all already have one of these calculators. So this is from MD Calc. This is the NRS 2002. It's one of the two screening tools that are validated in ICU patients, and you can categorize your patient into low or high risk at sort of the touch of a button. In this first part of the NRS 2002, you can see that all of your patients will screen positive unless, again, some of our patients are in the ICU but not necessarily severely ill. And then it'll prompt you, if you check yes for any one of those, it'll prompt you to go on to this second part. And, you know, a lot of your patients will have severe pneumonia. A lot of my patients have major abdominal surgery, or they're 70, which gets you a point. And anyway, on this score, on this scale, again, you just click, and it'll shoot out whether your patient's high risk. Institute Nutritional Care Plan is what it says. So it doesn't tell you exactly what to do, but it'll tell you if you're high risk or low risk. If you want to make your job harder, there's this one called the Nutric, which I never ever use because you can see, since you have to put an Apache 2 and a SOFA score, we don't do IL-6s, but that part of the Nutric score is optional. So the only reason I'm telling you about these last two things is because when you go to the guideline, the Aspen guideline in JPEN or critical care medicine, that's what it will tell you. It will say, you know, for timing of beginning enteral nutrition, it'll qualify the things as saying for an NRS 2002 less than 3 or Nutric less than 5, then this. And since that's kind of where we wanted to end up in this whole discussion today, I wanted you to know what that meant. So when you are trying to decide how aggressive to be with feeding patients, this is kind of what you're going to come back to. You know, predominantly we're clinicians, dietitians are using that initial assessment that I showed you with the history of intake, weight loss, physical exam, but the guideline is written, you know, as referencing these two screening tools. So it's just math now, right? So anybody wants to can go in with a copy of the guidelines and a smartphone, figure the whole rest of this talk out pretty easily. So, you know, we have a hospital formulary with various nutrition formulas on it. I didn't pick Parative for any reason in particular. And with the smartphone and either the formulary or the back of a can, because on the flip side of this can, if you turn it around, it's going to tell you kcals per ml and protein and all that stuff that you need to know to figure out how much your patient needs. The nutrition assessment will already have been done in most cases by the dietitian. to tell you what your goal in the end, what your goal calories and protein will be, or you can figure that out pretty easily. One more slide on barriers, and I just like to emphasize this because, I love to take out my calculator and figure out, okay, I want to start the patient on 25 kilocalories per kilo of tube feeds and this much protein, and I calculate it all out, and I calculate the rate that I want the patient to get, and then something happens. And the next day I round and the patient didn't actually get a single drop, or they got 40 mLs. And, nothing's more frustrating than on rounds when you're planned from the day before. We said we were going to start cefepime and bank. What happened? Or we said we were going to do a BAL. What happened? So similarly, there's lots of potential barriers. I'll put up one of my favorites. In our ICU, this is one I hear the most commonly. The patient's abdomen's distended, or I can't hear bowel sounds, or they just had surgery yesterday. There are all sorts of various concerns that come up. But the bottom line is usually what people are alluding to. The tracheal aspirate looks like tube feeds. Is that this is what people are worried about. So to sort of, address all of these things, this is the sort of title. This is the guidelines that I mentioned. Bless you. So for adult ICU patients, all of these things, the safest way to deliver enteral and/or parenteral nutrition for patients is more or less to follow, what we know to do based on various studies. And this is a summary. So again, I like to put the important stuff up first, so that if you have to tune out, and I was joking with Cindy earlier too, check what rink my kids' hockey game's on this afternoon. If you have to tune out right after this. So these are the summary of the 2016 guidelines, and so what we have spent the last 40 minutes talking about is this assessment. Assess the patient for nutrition risk, and then calculate energy and protein requirements, and that's pretty easy to do with whatever formula you like to use. The bottom line is whatever means you choose to do it, it needs to be reassessed for, and you can reassess in a number of ways, either clinically or with a metabolic chart. And then initiating tube feeding, so start something. This is a lot of times we're sort of like my residents in particular if they admit a patient on a Friday, sometimes I'll round on Monday and the patient will have gotten nothing for 3 days, even like a severe head injured patient or someone that clearly would benefit from nutrition, because they're waiting for the dietitian to make recommendations, and no one's come and made any recommendations yet. And so I do my little song and dance soapbox routine that's familiar to many of the residents that round with me about this. It doesn't, I don't care what you start. There's I think part of it's information overload. On our formulary we have 15 formulas, but if you follow the guideline, it just says to start the basic polymeric formula. There's really no, there's very select situations in which some specialty formula is recommended. So you're never going to go wrong by starting with the basic polymeric formula, which in this hospital is translation longevity, and I think that's what you guys have in your protocol in the MICU. So start something, anything. That's bottom line number 2. And increase the goal over the first week of stay. And take the steps needed that we know reduce the risk of aspiration and improve tolerance. Chlorhexidine mouthwash, elevating the head of the bed. If the patient's not seeming not to tolerate, you can do something about it. So this is also, if you're talking about a patient on rounds and for whatever reason you don't think they're tolerating gastric tube feeds, then the next steps are to just move on to the next system and talk about endocrine or renal or whatever comes next. No, right? The next thing is to troubleshoot, well, what should we do next? Should we add a motility agent, or should we try to get post-pyloric access? Should we kind of troubleshoot what's going on? I think the easiest thing sometimes is to just keep fasting the patient and move on to the next body system. But our patients will do better if we put our thinking caps on. So, and then the fourth one up here, implement feeding protocols with institution-specific strategies. And I'm pretty sure you guys have one. I don't know what happened with the EPIC transition, how it made it into EPIC or not, but I know because I worked on one with Dr. Mendez when he was still here. That's how I kind of know what used to be on it anyway. Don't use gastric residual volumes as routine care. Now, that's written into our hospital policy on enteral feeds to hold for greater than, does anyone know? 500, yeah. So you can't really get around that because the nurses are always going to shut off and give you a phone call. But I would challenge you to then, plan on what your next step is going to be. Is it going to be post-pyloric access? Is it going to be TPN? Sort of what is the plan? And sometimes it's a little bit of a dive into why, like why is the patient's, why their bowels don't work. Do they have, acalculous cholecystitis or something else going on? And then start parenteral nutrition early whenever enteral nutrition is not feasible or sufficient in high-risk or poorly nourished patients. So, that goes back, historically, in that the patients that benefit from parenteral nutrition, for whom the benefits outweigh the risk of infection and clots and stuff like that, are the high-risk patients. And that's kind of, so this is a little slide I made now to get away from those fuzzy copy-paste things for a minute. So the basics are, feed enterally early if you can. You should have reduced mortality, reduced infections, and then you can modify what you're doing. So when to be aggressive versus not be aggressive can be based on if your patient's high risk or low risk when you do your clinical assessment or your screening tool. And then you want to assess tolerance and adequacy. This is another Dr. Field slide. I threw this in here because I think, again, this is probably a little bit below your level. You guys probably already do something like this when you're trying to think of, how you're going to approach enteral feeds in patients. But this is always, for me, this is my question to my learner who's rounding with me. If they ask me, what or when to start enteral feeds, I'll ask them, so, is the patient at risk? So, are they, what do you think their nutritional status is? Do you think they're going to be eating within the next few days? And then whether or not you can use their gut. 9 times out of 10, when my residents don't think you can use the gut, you probably can, at least a little bit to be of benefit, right? And give, so the intestine sees some nutrients. And then the other kind of like down and dirty calculator parts are the volume. So, this is always tough because we calculate calories and protein, and then we come up with this volume, and then we look and see, well, the patient's getting 1.5 liters every day just from antibiotics, and another 0.5 liter from insulin and heparin and whatever else is going, right? So sometimes we want to volume restrict what we're giving them enterally. And that's hard to do because then the more you volume restrict the patient's feeds, the more hyperosmolar they are, and then you'll have more diarrhea. So everything's kind of weighing the things out. So if I just want to get something started, then I don't worry as much about the ultimate formula that is my goal to end up on in the patient. Like, say I really don't, if I calculate out my goal for longevity and it's, 1,800 milliliters, but I really don't want them to get that volume. If I just want to get something started, I start it, assess them for tolerance, and as they get closer to goal or halfway there, then I might start tweaking the formula around to see if they'll tolerate something more concentrated. But that's all just kind of experience and reassessment. And then electrolytes. We have obviously electrolyte restricted formulas for some patients that need them. Bless you. So I think I have about 3 slides left, but these are just some of the diagrams from the guideline. This is the one for early versus delayed enteral nutrition, and this is always one of the problems with nutrition literature, because you can look at all these different papers and everybody did something slightly different. Early defined as what, right? Delayed defined as what? In what patient? In trauma patients, and MICU patients, and so that's why sometimes it's nice to pool this stuff to see that, okay, maybe it doesn't matter so much. The recommendation stands at 24 to 48 hours. Early versus delayed for infections, so there's benefit for mortality, benefit for infectious complications, and then here's enteral versus parenteral. So for infectious complications, so enteral nutrition is obviously favored, and I don't think I'm showing you anything new. Just a couple representative slides. These recommendations didn't really change from the last iteration of this. And then, I brushed over a little bit of when to consider parenteral nutrition. It's essentially any time your gut either doesn't work or it's just inadequate. So maybe you have, enough bowel in theory that'll absorb nutrients, but it's just not enough, either because you're having some malabsorption issue or proximal fistula, things like that. Or, we see this. These patients that literally go to the OR every other day for wound washouts, their gut works just fine. But if you have to fast someone every day for, you fast them every day at midnight and they don't get fed until like the next morning. We sometimes have patients like that on TPN, and I think it's a travesty that we can't get them enough calories enterally, but sometimes you just can't. It's relatively unusual. All right, I lied. I had to put something in here about SMOF. This is literally the last thing, just because I think it's probably one of the newer topics in the guideline that's probably relatively unfamiliar to most of us. So what is a SMOF? So you guys know intralipid. When you order TPN, you get intralipid. So intralipid is pretty much all, or something like it, is a soybean oil derived lipid infusion, lipid emulsion. Okay, it's what propofol is in. That's what all of us have used for forever and ever. In Europe, there are lipid emulsions that are made not from soybean oil, but from any combinations of medium chain triglycerides, olive oil, and fish oil, and that's what the SMOF stands for. So when these guidelines were published in 2016, there was really no recommendation about who benefits from SMOF, when to use it. I'll show you. one other slide on this. But now, because we didn't have one in the United States, but now we have, we do have these available, and we have one that you can get for your patients. It's a non-formulary request. The thing is, we don't really know who benefits from it, so I think that's what we're going to try to figure out. The current recommendations, if you talk to our nutrition support team, are to consider it in patients with parenteral nutrition-associated liver disease, which is fairly uncommon, but you'll see it in patients who have been on TPN for a long time. Or in your septic patients with acute liver dysfunction. But there's no evidence really to back that up at all. This is, I put this up here in case anybody was interested. This is a systematic review, and it's basically 12 randomized controlled trial, but it's like comparing apples and oranges. There's all of these different components are different in many of the trials, so and it's different patient populations. So they showed a trend for some benefit in terms of ICU length of stay and ventilator days, but nothing statistically significant in this meta-analysis. So if you guys see this, that I just wanted you at least to have had a little bit know that we do have one. So in summary, we talked about looking for and diagnosing malnutrition, and in particular considering the role that inflammation plays on our patients' nutrition status. And when we have patients that are at risk, feed them early, use enteral nutrition when possible, acknowledge and address barriers. So, patients get that, breakfast tray, or, they get, tube feeds hung and they're not running. So try to address, what are the issues? Why are the tube feeds on hold? Oh, they just got their Dilantin. And every time they get their Dilantin, the tube feeds have to be held an hour before and 2 hours after, or something like that. So it's being held for 9 hours a day. Well, shoot, that means I better increase the rate, the other, hours of the day that it's actually running. So the things that are barriers that we can work around. And then I just put this up here so to sort of entice any of you who can think of new approaches or innovative use of an existing solution for another problem to help, because I think my opinion, and having been here for 10 years, is don't rock the boat. If a patient can be kept in bed and fasted, and don't touch. The default's always to fast our patients, and we struggle with that down in P4. So I think that if you were to sit in our morbidity mortality conference, you would see this. If something bad happens to a patient and they were getting tube feeds, it's always the tube feeds. The patient aspirated. It's always the tube feeds. But if they weren't, then the resident has to stand up there and try to come up with, think about what actually might have happened. So it's very interesting. So anyway, I'm happy to answer any questions or hear any comments that you guys might have. I hope that was helpful. Maybe if you guys want more on guidelines and specifics, I can come back. We can do nutrition part 2.